Hello everybody and welcome back to Synapse. I'm Ritika and in this video we shall talk about mitral stenosis. Before you watch this video, I would really suggest you to watch the previous two videos, one on the basics of heart sounds and the other on splitting of S2. It will really help you build your concepts way better. Let's dive right into this topic. The most common cause of mitral stenosis is rheumatic fever. There is a separate video on rheumatic fever. I would suggest you to watch that. I shall leave the links of all of these videos in the description box. Let us understand the pathophysiology and the clinical features in mitral stenosis. So in this diagram, we're going to concentrate on the left heart. So as shown here, there is a small opening of mitral valve. Because of stenosis, it has become smaller, because of which the left atria finds it very hard to push all the blood into the left ventricle, because of which the pressure in the left atria increases over time. This can build up the pulmonary venous pressure, lead to breathlessness. The normal size of the mitral valve is 5 centimeters square in area. This can reduce to as much as 1 centimeter square or lesser in severe mitral stenosis. And it becomes symptomatic from 2 centimeters square onwards. Anything greater than 2 centimeters is usually asymptomatic. As already mentioned, the left atrial pressure increases. And this will eventually lead to left atrial dilatation, something like this. And left atrial dilatation can lead to atrial fibrillation, and we know that atrial fibrillation can anytime lead to clot formation in the atria, and this clot can get disseminated into systemic circulation, and it can even lead ischemic stroke. So the dilatation and increase in pressure in the left ventricle, as already mentioned, can lead to pulmonary venous congestion, and over time it can even lead to pulmonary arterial hypertension, which can lead to right ventricular hypertrophy. So this is certainly important to understand that though the pathology lies in the left heart, that is mitral stenosis, hypertrophy is seen in the right ventricle. With time, this can even lead to right ventricular dilatation, leading to tricuspid regurgitation. It can just go as far as tricuspid regurgitation and eventually leading to symptoms of right heart failure, such as pedal edema. So it starts off with the symptoms of left heart failure, that is pulmonary edema, breathlessness, etc. And it can extend into the right heart, leading to right ventricular hypertrophy, dilatation, tricuspid regurgitation, right heart failure symptoms such as pedal edema, etc. Let us now look at the clinical features all in all together. So one was dyspnea on exertion, hemoptysis and cough, explained by the pulmonary edema in this pathology, palpitations and thromboembolic events because of atrial fibrillation, chest pain due to pulmonary arterial hypertension, edema or ascites that's due to right heart failure. What do we see or hear on examination? On auscultation, you will hear a loud S1, that is, the first heart sound is louder. This is because the left atrial pressure is very high. So there's a higher pressure opening the mitral valve, because of which even the closure of the mitral valve, that is the elastic recoil of the mitral valve, will be high, leading to a loud S1. This can even be palpated and it is referred to as the tapping apex beat. The next finding is a loud opening snap. The reason has already been mentioned. It's because there's a greater pressure in the left atria that the opening of the mitral valve happens with greater force, and thus there's a louder opening snap. And I'm telling you again, you will understand this concept really well only after watching the heart sounds video. Now let us understand the characteristics of the murmur heard in mitral stenosis. So coming from S2, so S2 occurs, that is the ventricle has started dilating, that is diastole of the ventricle has started, the aortic and the pulmonic valve close, causing the S2. And then there is isovolumetric relaxation until this span is isovolumetric relaxation, and then the mitral valve opens. This opening of mitral valve has become louder, it is a loud opening snap. And then the ventricle continues to dilate, that is to relax, and the blood flows from the left atria into the left ventricle, leading to a mid-diastolic murmur. The part that I have marked right here is passive ventricular filling. And as the blood passes through the stenosed mitral valve, it leads to this murmur, which is a mid-diastolic murmur. And after this is the atrial systole. Atrial systole, as it causes an increase in the pressure, it pushes the blood into the ventricle with greater pressure. It leads to an accentuation of the murmur. And because the systole starts from here on again, the ventricular systole, this is called as the pre-systolic accentuation. So the main characteristics of the murmur heard in mitral stenosis is the loud opening snap. It is a mid-diastolic murmur with pre-systolic accentuation. The investigations that you should be doing in these patients include ECG, where you can see right ventricular hypertrophy represented by tall R waves in V1 and V3. P mitral. So P mitral is seen when there is left atrial enlargement. We know that left atria pressure is increasing, left atria is getting dilated, that is, there is left atrial enlargement, because of which the P wave representing the atrial depolarization takes longer, because depolarization wave takes longer to spread across the atrial mass because the atrial mass is increased. There's enlargement of the left atria. So the P wave gets elongated, and a notch might be seen, characteristically seen in some ECGs. But the main point is that the P wave has been elongated. It's taking longer time, and that is represented or called as the P mitral. Next investigation is chest X-ray, where you can visualize the enlarged left atria and pulmonary venous congestion. Echocardiography is a very good investigation where you can very clearly visualize the valve, that is the valve area, the thickened cusps of the valve, the enlarged left atria, and you can also visualize there is a reduced rate of diastolic filling of the left ventricle. Doppler would show the pressure gradient across the mitral valve. That is, it will help you understand that there is increased pressure in the left atria, and it also help you understand about the pulmonary artery pressure. Cardiac catheterization can be done when necessary, but it is an invasive method. So how would you treat mitral stenosis? First, we would try and treat it medically, and the drugs we would want to use is anticoagulants. That is to prevent coagulation and clot formation in the left atria, leading to thromboembolic events. 2 is diuretics, and this is mainly to control the pulmonary congestion. Antibiotics can be given prophylactically to prevent infective endocarditis. But if medical treatment is not helping, then surgical methods have to be opted. We have mitral balloon valvuloplasty, which is very useful. Valve replacement can be done when the valve has become rigid and calcified. So here I end the discussion on mitral valve stenosis. I hope you found this video very useful, and if you did, like the video and share the video to support us, because that will motivate us to bring more videos for you. Bye bye until the next video.